This is Jennifer Seven, and I am so excited to be on our Empower Hour, our Menopause Map FemPower podcast. And I have an incredible guest tonight. I have Dr. Kajal Roy, and she is the medical director of Nyon Medical in Leesburg, Virginia. Dr. Roy is deeply passionate about holistic medicine. She takes a very proactive, preventive approach to health and wellness. She is double board certified in internal medicine and obesity medicine, and she is a proud member of the Menopause Society and the International Menopause Society. And I just want to remind everyone this conversation is educational. It is not medical advice, anything personal you'll want to discuss with your own clinician. So, Dr. Roy, thank you for being here. I'm so happy to have you on.
Thank you for inviting me, Jennifer.
You're welcome. So I thought it would be appropriate to jump in. We're going to have this conversation about menopause and hormones, but I always like to start with, what's your story? Give us a little bit of your story, what led you into the work that you do.
Sure. So I think looking as far back as I can even think, I think my journey through perimenopause probably started in my mid to late 30s. We were building a house. I had two small kids. I was working in the hospital. And I was walking through the hospital, rubbing my chest. And I thought for 2 seconds, I was like, oh my God, is this a heart attack? I'm only 36. And a friend of mine, luckily, who was a cardiologist, was walking by and he was like, what's wrong? And I was like, I don't know, it's just stress. It's just stress, the house and all the things. And so he was like, are you working tomorrow? And I said, no. And he goes, well, my office, 9 a.m. tomorrow, nothing to eat after midnight. We're doing a stress test. So I was like, okay. And so here I am, 36, in the cardiologist's office. And I got a stress test, an echo. I did like the on the treadmill stress test first and then the echo. And then they even did the nuclear stress.
Okay.
And then we couldn't find anything. So I went home with a Holter monitor for a week.
Oh my.
Still nothing. And so then I was like, okay, well, it's just stress. That's fine.
Yeah.
I'm 36.
Two kids working hard. Yeah. Building a house.
Yeah. 12-hour shifts. What do I expect? And a ton of coffee.
Yeah. Oh, okay. We have the caffeine going on.
Yeah. So then, fast forward, still working in the hospital. And I, in internal medicine, in all forms of medicine, you have to write your board exams every 10 years. And so I took my first board exam in 2010, 4 weeks after my first son was born.
Oh, goodness.
Okay. So back then I was at a newborn and I was flying through the material with the books on my couch and it was sticking. Now he's 10 back then in 2020, he was 10. And they know, like both my kids, so at that age, they were 9 and 10, they know when mom's studying, you got to leave her alone. And I would study and then I would go and like put laundry in and stir something on the stove. And then I would come back and I would be like, what was I doing?
Oh.
What was I reading? And then I would read it again and I would be like, that doesn't make sense. And mind you, I've been practicing for 10 years in the hospital. So this should be just sticking. And so for a long time, I struggled. And finally, I went into my doctor and I said, something's not right. I don't know. Maybe I've got adult onset ADHD. I don't know. So she told me to meditate and I left.
Oh, lovely. Okay, great.
Yeah.
Just calm down.
Just calm down. See a therapist was the other thing. And I was like, no, there is something going on. I don't know what it is. I don't need therapy. I don't need to maybe I do need to meditate, but that's just not my peaceful place. I think that stresses me out even more. So I was like, okay, I'm just going to do my own labs. So I checked my own labs. My testosterone was less than 3. Um, my estrogen and progesterone and my FSH was kind of like within what looked normal.
Okay.
So I was like, okay, let's just start with testosterone. So I found a provider. I started testosterone replacement, and I started flying through the material, and it was sticking. And took my boards, I passed them, and I have not looked back since. And so now when I have other symptoms kind of creep up, I'm like, oh, okay, this is associated with estrogen, and this is associated with progesterone. And I have advocated for myself. And I started in 2020 was when I started doing hormone replacement in my practice, because that was when I was like, everybody's dealing with this.
Yes.
And as a physician, I didn't even realize what was happening. And so I was like, there's probably so many women out there that, medical professionals or not, are going through this, and they
Don't
don't
even know why.
know.
They
They
don't know
don't
what's
know.
happening.
And that's when I just kind of started my journey down learning more about menopause. And unfortunately, we weren't really taught about it, because back when I did my residency, it was 2007. And so around that time was when all like 2002, I think, was when the WHI study came out. So they were like, screech, halt. We're not teaching this stuff because it's not going to be useful. We're not going to use it.
Right. So just nothing.
So
Nothing on
don't teach
menopause.
it, because there's no point in teaching it. So we missed out, and we didn't learn about it. And then I didn't know what was going on with myself. So
Right. And thank you for sharing all that, because I think women need to know that there is a lot more that's going on that are related to hormones and menopause than we even could imagine.
yeah.
So before we totally jump into hormones and that WHI study, I thought it would be great if we just brought everybody up to a baseline of just what is menopause. And let's start with defining perimenopause, menopause, and postmenopause, so everyone really is on the same playing field, so we all know what we're
Okay.
talking about.
So let's start with premenopause. So
Okay.
premenopause is it's when your cycles are normal, everything's working okay, you're not having any symptoms, everything's good. Perimenopause is when you start to have any of the symptoms. So that could be fluctuations in your period, mood swings, irritability, that kind of stuff. Perimenopause actually encompasses menopause and 1 year post-menopause. So it's perimenopause.
Okay.
Okay. And then the menopause is that 365 days without a period. And then post-menopause is day 366 onwards.
Okay. So really, women spend a great deal of their lives postmenopausal. I mean, we always say, "Oh, we're menopausal," but we're postmenopause.
Postmenopausal.
Yeah. So
Yeah.
that's
And that
yeah.
perimenopausal time, I mean, that even before you hit menopause itself, that premenopausal time can last like 7 to 10 years. It's a long time.
Well, I think I've read somewhere that symptoms could possibly not even show up for 7 years.
Yeah.
So would that be like premenopause before you even hit or that's kind of
It would be yeah, where
it's starting.
yeah, it's where it's so gradual that you don't know that it's happening until it slaps you in the face.
Mm-hmm.
And then you're wondering, like, why can't I do the things that I was
That I
doing?
could do. Yeah.
Yeah.
And then we blame them on so many other things. Like if you can't
Uh-huh.
sleep, you get a sleeping pill. If you are
Yeah.
scattered, you're ADHD and get a ADHD medicine. Or if you're
Hmm.
depressed, you get depression medicine. It's not, nobody's looking at
Yeah.
what's going on with the hormones. Yeah.
Yeah. So, yeah, I mean, even like when that whole chest pain situation, um, it didn't resolve when I cut back on the coffee.
So it wasn't coffee. It
wasn't
wasn't
the
the
caffeine.
caffeine.
So I had to pick that back up right away.
Right? Bring it back.
Yeah. So yeah, it was just you don't realize until you kind of hit the wall, and then you start actually teasing it back and thinking, oh my God, like I was doing all of these things. And we'll talk about some of those things because I now realize like, oh, that's why I was behaving the way that I was behaving.
Mhm.
Um, so yeah, it's pretty sad. It's sad to go through it without knowing, and then looking back and being like, oh crap, I missed out on a lot of stuff.
I feel that very strongly. I look back on my life, and the more I study this and the more I learn about it, the
Mhm.
more I think, oh, wow, we're taught in school about periods and about how we can get pregnant
Yeah,
and about how not to get pregnant. And then we get pregnant and we learn about that and we learn about babies and we learn a little bit about postpartum. And
yeah,
then it's like, and someday you're going to have menopause,
and you're on your
when
own.
you're old,
Yeah,
when you're old and it's just
yeah,
whatever, let's just
yeah.
deal with it. So I'm excited that this is becoming more of a conversation for women, but I still think there's so many women that have no clue. So what I would love for
Mhm.
you to talk about is there's the common symptoms. There's the ones I think most of us know about, like hot flashes,
Mhm.
weight gain around the middle, maybe mood a little bit of an erratic mood. We hear about the
Uh-huh.
women that, oh, they're crazy when they get into
Yeah.
menopause. They become wild or bitches or whatever.
Mhm.
But there's so many other symptoms. I mean, could you just share a few of, I mean, first of all, isn't it something like 49 documented, but now they've come up with
I
like
think it's like
100.
68 or something. I don't know,
I mean,
something
it's
high.
incredible. It's
Yeah.
incredible. So just could you just share a few that are uncommon that we might be like, oh, wow, I had no clue that could be related.
Yeah. So anxiety.
I know, that's huge. I think
Mm,
someone told me that that's one of the top ones. And I'm like,
yeah.
you're kidding me. You're kidding me.
Yeah.
Anxiety. Who would have thought?
Um,
Yeah.
yeah. One that I didn't even withdraw, being withdrawn.
Mm,
Um, Secluding yourself, like not really wanting to interact with whoever. Um, you know, I look back and I think, gosh, I remember going to pick up my kids from they we used to go to this country day school when before they started kindergarten, and I would go to pick them up, and I would just think, oh, I'm just going to go. They're going to be playing in the playground, and I had this thought. I was like, I'm just going to go run and hug them. I just want to hug them because of all of the crap I saw at the hospital. Just
mm-hmm.
everything every day was like just doom and gloom. I want to go wrap my hands around my kids. And I would get there and I'd walk fast and I would stop. And I never could understand, like, why am I not running to my kids and picking them up and hugging them the way that I want to? But just something inside me would just stop.
Interesting.
And I was like, what's wrong with me? What kind of mother am I? You know?
Mm-hmm.
Um, and you know this, I mean, I adore my kids.
Yeah.
But I don't know. It just there was something inside that I was like, don't not too close.
Yeah. Interesting. Yeah.
Um,
Like that withdrawal or a little maybe depression even.
yeah,
Yeah.
yeah.
One that really shocked me was just the muscle and joints aching.
Mm-hmm.
And I've heard so much about I
Frozen
can never
shoulder.
say it, frozen
Yeah,
shoulder. And I was
yeah,
like, really?
yeah.
How interesting is that?
And the
That's,
plantar fasciitis.
yeah,
I
yeah,
think everybody has that.
yeah. Right. And it's like, no, but you're not treated for it other than
Hmm.
you get a shot in your heel of cortisone or
Hmm.
something.
Yeah,
It's never a hormonal discussion ever.
yeah.
Dry eye, dry skin, skin
Mm-hmm.
breaking out. I was like, I've met this one woman. She goes, oh, I had a terrible trouble with dry eye, but no one ever
Hmm.
even remotely thought that it's related to hormones. I was like, gosh,
Cavities.
oh, I didn't know that one.
Cavities because you're the dry mouth.
Oh, dry mouth.
Hmm.
Yeah.
Yeah.
Wow.
Yeah,
And
actually, dentists can find things a lot sooner, I feel like.
because they show up
Um,
there first.
yeah.
Interesting. And we know now that blood pressure maybe goes up,
Mm-hmm.
can go up, and we'll talk, heart health and bone loss and all of that. All of
Mm-hmm.
that's occurring related to our hormones. I'm trying to think if there's any others that really jumped out at me, but there's a lot. There's a
There's so
lot.
many itchy ears.
It's
Like,
great, great.
yeah.
Why are
You
my
know,
ears itching?
yeah, it's just, oh, I have phantom smells. That
Yes.
was one. I get that one. I think I've told you about this. Like
Hmm.
my kids, I'm like, do you guys something burning? And they're just like, you're just losing your mind, mom.
Yeah, yeah, right.
There's nothing burning.
Mom, you're weird.
Yeah. Burning rubber or just smoke. Yeah, I don't, and there's nothing burning.
And no one else is noticing it.
Mm-mm.
Just us.
Yeah.
So what I know it's fascinating, all of the different symptoms, and I just think there's probably more to come.
Mm-hmm.
But what do you think are some of the early symptoms of perimenopause that women might miss or mislabel it? Early symptoms.
Fatigue.
Oh yeah.
You know
Oh
what
gosh, yeah.
we're big, we're people that we're our gender we do make excuses. I do it too. Um, oh, it's just because I have like all the kids stuff and I have, the house stuff to do and I've got work and I've got this and oh, no wonder I'm tired. That's what it is. It's just I'm
Yes.
just so busy.
Yes. Yes.
So I think that's one of the big ones is that fatigue, like not being able to keep up and do the things that you used to do maybe 2 years ago.
That one hits me really hard because
Mhm.
I remember I was tired all the time and I just wanted to take naps every day. And I blamed it on having little kids and running around, but it's just like I just needed a nap every day, every day. And I'm
Yeah.
thinking about that now and I'm like, when's the last time I've had a nap? It's like
Yeah.
that was, and I didn't sleep well. Sleep was huge, huge
Yeah.
problem for me. And it was like, here's your Lunesta or your Ambien, which my kids thought
Mhm.
was hilarious because they would come in and talk to me. And I would talk to them. Well, I was just like, I would remember any of it. But that wasn't great. I didn't like
Yeah.
that feeling. And then it made me feel even more tired
Yeah, it makes you
during the
so
day.
groggy and yeah.
I mean, we know the
Yeah.
common one is you start to miss your periods here and there.
Yeah. Yeah, that and the hot flashes and the night
Hot
sweats,
flashes
that's all
start.
very common. Well,
Yeah.
those are the most commonly talked about. I think those are the most distressing.
Mm-hmm.
There's the other symptoms like the fatigue, the anxiety, the um, uh, irritability.
Mm-hmm.
We just chalk it up to life.
Life and stress and just having a family and running around like
Yeah.
crazy
Or
women
even
doing
like
everything.
the not caring what other people think.
Mm.
You know how when some people say, "Oh, you hit 40 and you just stop caring what everybody else thinks about you."
Right?
I don't think it has anything to do with like being 40. I think it just has to do with that time of life where your hormones are kind of going and you just don't have time for everybody else
Yes.
because
Yeah.
there's so much internal going on that you can't.
Yeah. Just trying to manage
Yeah.
your life.
Yeah.
So when do you think it's appropriate for a woman to start to think about booking an appointment if she's starting to have symptoms instead of trying to just self-manage herself? What's kind of I don't know, what would be something that you say, you know what, it's time for you to get in there?
I think the sooner the better. Only because it doesn't have to be medication. And I think we're going to probably talk about that later, but like, at least to know your options, see where your baseline numbers are,
Mm-hmm.
you know, kind of, I think it would be wonderful if we could get baseline numbers in our 20s, early
Wouldn't it be nice if
30s.
that was just part of our
Yeah.
OBGYN physical?
Yeah.
Every
Just
year you've got
to
your
know,
numbers.
especially your testosterone. Like nobody checks your testosterone and um it's it apparently it's just we don't need it for some reason. The FDA says we don't need it. I don't know. There are studies out there where it's been proven to be helpful in women. Um, but wouldn't it be nice to know like what testosterone level we felt good at?
Mm-hmm.
So then that way we're not kind of like there's no, like when you're doing your testosterone, it's kind of like, well, we'll just kind of keep going up and see how
And
you
and then
feel.
traditionally, that's not something that you're going to be treated for, right?
Yeah. I mean, it would be great to have a goal.
Hmm.
We know your blood pressure's goal is like 120/80. It'd be kind of nice to have a baseline.
Yeah,
Yeah.
definitely. And correct me if I'm wrong here, but isn't it better if we can keep our levels optimal for as long as possible to try to not go into menopause, just to keep, am I saying that right? Um, Trying
Well,
to keep everything optimal for as long as we can.
so yes, you want to keep it optimal for as long as you can, but you're also keeping it optimal so you're not suffering through the whole process.
Hmm.
There's also other reasons why you want to optimize your hormones, because they do offer good things for us. And we're going to get all into the like
Yeah.
what estrogen does and all of that stuff. But um, it's not even a matter of pushing off menopause till later. It's just managing it as you go,
Hmm.
so your hormones aren't going all over the place and you're not
The
riding this crazy
erratic.
roller
Yeah,
coaster.
it's
Yeah,
erratic because they're very erratic, right? They're up,
yeah,
they're down, they're all around. Yeah.
yeah.
Well, I think that's a good place then for us to dive into hormones. But the first thing I want to talk about is, so many of us were taught to be afraid of hormone replacement therapy, and there was this WHI
Hmm.
study. So, can you just share with us a little bit about what that was and why it scared everybody so that we
Yeah,
didn't get supported in that way?
yeah. So the study was done. It was the largest study that they did for women. And it was a brilliant study. It was really good. The main focus of that study was hormone replacement on cardiovascular health. Had nothing to do with breast cancer.
Okay.
Okay. Um, so what they did was they took these women. They were all above the age of 62, I think, something like that. They were all postmenopausal, and they were placed on estrogen. And if they had a uterus, they were also placed on progesterone. So those were the two arms of the study. Um, they stopped the estrogen progesterone arm of the study prematurely, because they noticed an uptick in breast cancer. Um, when they and the other arm, the estrogen study, kept going, because that one showed a decrease in risk in cardiovascular disease, a decreased risk in osteoporosis and fractures, and a decreased risk in breast cancer. Um, so what ended up happening, and this piece I just kind of learned the other day, where all the investigators were kind of like, hold on, okay, we're just going to pause this arm of the study and kind of analyze and see what's going on. They didn't want to reveal any results. Apparently, two of the investigators were like, we need to report this because this is not good. So without telling the other investigators, these two went and did a press release, like a press conference, which is kind of weird. You don't do that in the middle of a study.
Hmm.
So they said, when they came out, they said estrogen causes breast cancer. If there's a relative risk, it is 24% chance of increasing your risk of breast cancer. Well, in medical research, absolute risk is what you really want to look at. So if there were, let's see, normally there's 8 people develop breast cancer, whether you're on estrogen or not. There were an additional 4 out of 10,000.
Okay.
So when you look at the absolute risk worked out to be like 0.08%.
So it's very, very low.
So very low. They just reported it wrong. So then what ended up happening was physicians stopped prescribing. We weren't taught. And everything just kind of got shut down.
It was
So
huge headlines. I mean, it
it's
was
huge.
really out there in the
Yeah.
press. The press took it and ran with it.
Yeah. And they did. And so somebody had actually said, well, why weren't there people like saying, no, that's not true? We didn't have social media back there.
Mm.
You
Hmm.
know, the news was our social media.
And you believed
Um,
whatever was in the news.
yeah. Yeah.
Yeah.
So that's why it's becoming really big on social media now, because now we have a platform to say, hey, you know what? That was wrong.
Yeah. So talk about that. So just this past year, I think it was maybe in November, so what they did was they put this black
The black
box
box warning.
warning.
Hmm.
So it was basically like danger, danger, prescribe this, you're
Yeah.
going to die.
Yeah.
So I remember I was terrified of it because we'd heard, oh no, that's going to give you
Yeah.
cancer. And that really makes me mad now because we'll talk a little bit more about this, but the benefits, there were so many benefits to it
Hmm.
for heart health and bones that I missed out on.
Hmm.
But they did come back around and took the black box label off of it just recently, just
Yeah.
this past
Just
year.
last year. Yeah.
Yeah. So
Yeah. It
that's
was
changing everything, right?
huge. Yeah. To the point where some of the estrogen doses are on back order.
Yeah, I saw something about a big shortage.
It's like the Ozempic shortage.
Yeah, and it's a little bit less talked about, but it's so
Yeah, there's
important.
yeah. It's I mean, women want to take their lives back.
Yes. Oh,
You know,
yes.
which I think is great. I'm so happy that there's a back order. You know,
Hmm.
because that means that women are like,
Women are looking for
yeah,
it. Yes.
yeah.
And for our listeners, I would say there's a great book. It's called Estrogen Matters,
Hmm.
and it really goes into the study and really shares how it worked, why it was really flawed in that area.
Hmm.
And so if anybody wants to go deeper, that's a great book to
Yeah.
look at.
Another part of that study also was it was using uh, Premarin. So Premarin is synthetic estrogen that is taken from pregnant horses' urine.
Okay.
So that was another piece of the puzzle. And then they were also using medroxyprogesterone acetate, which is a synthetic progesterone. So
Okay.
that was also a big part of the problem.
Okay. So now when we talk about HRT, is it the natural,
Hmm.
not synthetic? Okay,
Yeah.
so tell what is the purpose of HRT, hormone replacement therapy? What are we trying to do for women with it?
So we're not replacing. We are helping it along. So when you think so HRT, when you're saying HRT, that is including all hormones.
Okay,
Menopause hormone therapy is you're working on your testosterone, estrogen, progesterone.
okay, so
Okay.
that's specific to the
It's very
menopause.
specific, just those three.
Okay,
So when you're talking about menopause specifically, you're not trying to replace it to the point of when you were like a teenager. That's not you don't want to do that because
okay,
nobody wants to go through puberty again. We just want to optimize your hormones enough to help you get through the symptoms and for prevention of diseases that come along with
mm-hmm.
having hormones that aren't optimized.
Yeah, yeah, and yeah, so to manage those symptoms and improve
And
your quality of
prevention of
life,
yeah,
right?
yeah,
Yeah.
yeah.
Is it ever too early or too late to consider HRT? Or should we just be calling it, what do you call it?
MHT.
MHT. Okay.
Um, it's I think the earlier the better.
What if you feel like, oh gosh, I'm over 65. Is it too late?
If you're over 65, it just takes additional testing.
Okay.
Um, can it be done? Yeah. I have treated many women over 65, and they've gotten amazing results. I actually have one that I've been treating her since I think she was 65 when I started treating her. And I think she's 68 or 69 now. And she came into my office last year and she said, I'm moving. And I was like, oh, okay, where are you moving to? Panama. I got myself a boyfriend in Panama. And I was like, oh,
You go, girl.
okay. I was so happy for her. But she was like, I feel not like $1,000,000. I'm moving to Panama. I've sold everything here.
Wow.
And I was like, do it.
Yeah.
She's living her best life right now.
Yeah. So kind of what's the sweet spot? Is there one? Like, 65 additional testing.
Mm-hmm.
What's the age kind of before you have to do all the extra testing? 60?
So 10 years, if you are 10 years post-menopause.
That's when you'll start to need extra.
Yeah. And it's just because of what it does to your blood vessels with that estrogen level being so low.
Since you haven't had it. Right.
Yeah.
Yes. And from what I understand, you've got to be checking your bone density and because just even in perimenopause, that's when that starts to shift.
Oh, it plummets. Yeah.
Yeah. So that's another conversation, is to talk about our strength training, but we might have to do another podcast on that one. But I know that there's a lot of different forms. What do you think it matters? I mean, there's injectables, there's creams. Do you want to just touch on that a little bit? There's a lot of different
there's
types.
A lot. There's there's injectables, there's creams, there's patches, there's oral, there are pellets that's inserted under your skin. There's a lot of different options. I generally look to see how much can the patient handle.
Okay.
Number one, I have a lot of patients that are in and out of the country. So pellets just work really good for them because they last 3 to 4 months. They're not here to be able to pick up their testosterone monthly. So that's what works best for their lifestyle. But I think creams, you have to also consider how well does your skin absorb. Everybody doesn't absorb very well.
Okay.
So that's just something to think about. Oral estrogen, not a fan. Oral estrogen has to be metabolized through your liver. It does put you at a slightly increased risk of developing blood clots.
Okay.
Whereas the patches and the creams they don't have to go through the liver, so they go directly into your bloodstream. Okay. So there's no risk of that. And then, obviously past medical history. If you are an estrogen receptor positive breast cancer patient, that's a conversation. You can use things like vaginal estrogen safely. So there's just so many options. There are, and if estrogen is just off the table completely, there are other medical options that you can use too. There's non-hormonal treatments that are available.
And so it really is just very
individual conversation.
Right. Yes. Yeah. So we've talked about it's never too late to consider it. And just quickly, beyond the sex hormones, what are the lesser talked about hormones that we can be looking at in midlife?
Thyroid. So thyroid is one of the hormones that if that's not working to its best, everything it's like a trickle down effect. So everything kind of gets thrown off. So that's one that's really important to check. Insulin. Insulin is a big thing that I like. I like checking fasting insulin. I want to catch my patients before they become pre-diabetic.
Yes.
So then there's something that I can do about it. As we lose our estrogen, we start to accumulate a lot of visceral fat. That visceral fat is what makes us insulin resistant.
Okay.
So
big complaint a lot of women have. It's like, well, all of a sudden I have this belly that I never had.
Yeah. Well, and the problem is when you get that visceral fat because of the estrogen kind of going up and down, that makes you insulin resistant. When you're insulin resistant, that creates more visceral fat.
So it's this terrible cycle.
And then you get into this cycle where you're like, well, I'm still like, oh, well, I used to run 5 miles. Well, maybe if I run 10 and I cut back 500 calories and you're still gaining weight. So the old stuff that you're doing it's just not working anymore.
Yeah, eat less, exercise more. That is
That
just
does not work.
that is
Doesn't
debunked.
work. Yeah.
Yeah, so very much about the hormones.
Yeah.
What about the stress hormones and the sleep hormones?
Oh, yeah. So melatonin is one of the first things to go down, um, along with progesterone. So progesterone and melatonin work really nicely together for sleep. Um, Cortisol, I don't typically check cortisol. I mean, we're all stressed.
we live we
I
live in this
mean,
world
why do
where
I
we
need a number to
stress.
show me how stressed you are?
Right. Yeah,
There's,
find me someone who's not, right?
yeah, yeah. So I just don't check it. Cortisol, I always associate checking a cortisol level with other medical conditions. So yeah, if you're stressed, your cortisol response is going to be high.
Yeah. And so most of us are stressed.
Yeah.
I
Yeah.
would agree with that. I think
Yeah.
that's very true. Uh, so are there specific hormones or markers you consider monitoring, and how do you decide what's worth testing and what's noise? I mean, I think you've kind of touched on that a little bit.
So I feel cortisol is just kind of not necessary.
Okay.
Um, there are some things that are tested, like I'm trying to think. You don't need to do everything in everybody.
Okay.
So, like a DHT, which is dihydrotestosterone, I don't need to check a DHT in everybody. Now, if you're having hair loss and some of your other numbers are kind of off, then I might think, okay, let's just check it out and see, because DHT can clog those hair follicles and cause your hair not to grow.
Okay.
So I see there's a lot of companies that do this 500 biomarker panel, and then it just gets so confusing. You gotta take a clinical picture first and then order your labs for confirmation.
Yeah. Okay. So and then you can
Yeah.
hone in.
Yeah. Yeah. Same thing with imaging, there's a big thing in the hospitals where people are just ordering stuff to diagnose, and that's not the way you do it. Like you see the patient, you get a history, you figure out what's going on, you come up with your 3 or 4 or 5 things that could be possible, then you order the testing to differentiate what's happening. You don't order the test to find out what's going on.
Okay. Yeah.
So and then you find all of these, what are they called? Incidentalomas.
Okay. Yeah.
So it's
It
like,
could be a
it's like,
maybe, a maybe, a maybe.
yeah, then you're stuck with this number and you're like, well, I don't know what that means. Are you
Yeah.
having those symptoms? And then the patient's like, well, I don't know. Maybe.
Because maybe you put it in their head, right?
Yeah.
Yeah. So, because I know the big ones you test are the thyroid, the
Hmm.
testosterone, the
Yeah.
progesterone, the estrogen.
Yeah. FSH.
Yeah.
And then I like, the vitamins. So
Oh, and
D,
the insulin and the
B12,
vitamins.
and the insulin. Yeah. All of
Yeah.
those things. So
Yeah. And that
yeah,
gives you a good fundamental picture. And then you
it
can
gives us a
decide.
place to start.
Right.
And then if I need to dig a little bit deeper, then that's another conversation. But it's a good place to start and then come up with a plan and then kind of take it from there.
Well, and I like your approach also is that we're not going to go crazy. We're going to do a little bit at a time, or we're going to see how it works, and then we can
Yeah.
tweak it. We can tweak it. We can tweak it to see how the body responds to it.
Yeah. Yeah. Because if I throw everything in the kitchen sink at you, then I'm going to be like, well, I don't know what worked.
Yeah.
We'll
Right.
just keep doing it all.
Yeah. Yeah. Not necessarily
And you don't make, you
give you
may
the
not
answers that
necessarily
you want.
need it.
Yeah. And you may not need it. Exactly.
Yeah.
So, gosh, this conversation has just gone so fast, and there's so much good information. And we could just keep talking, but I did kind of want to start to wrap it up. Uh, from your standpoint, if a woman that's listening right now and she's feeling very overwhelmed or unsure about what's happening with her body, what would you advise her is the most important next step that you would suggest to her to take?
I would say talk to somebody.
Like a
You know,
doctor or?
no, I mean, even a girlfriend, you're not alone.
Mhm.
You're not the only one that's going through this. And I think the more we talk and we build these relationships and communities and we lean on each other, the easier it is going to be to get through it. Because on the other side, there's a woman that's wise and that's happy and that's joyful and is all the things. It's just you got to get there.
Yes, like how did she get there?
Yes, but she's there. She's there. It's just trying to get through the hard part to get to her.
Yeah. And I love that. I love that. The community, the support, you don't have to be alone because it can be very isolating. And I think for some people, they're very shy about talking about all of these physical things. That's like, I don't want to talk about that. Me, on the other hand, is like, whatever, let's talk about it.
I know. But, I do find even the shy women, where they're kind of like, oh, I don't know if I want to talk about it. If there's somebody that's willing to talk, those talkative women can draw it out of those shy women
and get them to feel safe.
Yeah. So we have to just keep talking.
Yeah, I love that. So if you are listening and you want support applying what you heard today, please join me in the free menopause map inside the Substack. It's the Menopause Map. And you can post your biggest symptoms. I will throw out some answers, but we have wonderful Dr. Roy here. She does have her practice in Leesburg, Virginia. And so if somebody really wants to start to jump in to finding out what's going on, she's great. I will drop her website into the show notes. So she's wonderful. She's great. Very knowledgeable. Yeah, it's great. So Dr. Roy, any last thing you want to leave our listeners with?
Don't listen to "this is just you aging."
Oh, thank you.
Really advocate for yourself. You don't have to go through it. I mean, there's so many options. So don't take that as an answer that you just have to kind of suck it up and deal with it, because you don't.
No, and there are practitioners who will listen. They might be hard to find, but you can find them, and that's a whole other conversation we could have on another podcast of what to ask and who to look for, but they are out there. So, and again, you're not alone, and so be part of the community. Dr. Roy, thank you so much for your time. This was so clear. It was so grounding, of so much good information, and I'm so glad we could share this with everyone tonight.
Me too. Thank you for having me.
All right. You're welcome. All right. We'll have you on again. We'll dive into another topic.
Anytime.
All right. Thank you.
Thank you.
Okay. Bye-bye.
Bye.